So I think 10 minutes of anxiety disorders is remaining. So we'll finish it off fast, then we can move on to your next lesson, that is personality disorders. Okay. Okay. So we were talking about specific phobias and basically regarding the causes or etiology of specific phobias. Okay, and we got disconnected at this point. So what causes specific phobias? Yesterday, while talking, I was mentioning that specific phobias, according to a behavioral perspective or behavioral model, specific phobias develop through conditioning. That is, sometimes, if you are if you have had a traumatic experience and then that particular situation or that particular object gets associated with you experiencing that traumatic event, and then later on you will develop fear regarding that object. Okay, and classical conditioning, I was trying to explain to you classical conditioning. For example, like, if there is a situation, a person gets entrapped or, you know, kidnapped or something like that. So this getting entrapped according to classical conditioning is unconditional stimulus, and where your unconditional response would be fear. Obviously, like, if you have been kidnapped or if you are entrapped, so you would immediately, in such a situation, you would experience fear. So while being kidnapped in that situation, while you're kidnapped in that situation, you simultaneously, or wherever place, whichever place you are, you hear, I mean, continuously hear water running. So what happens? These two get interconnected in your mind, and the running water plus entrapment, okay, will lead to unconditional response of fear. And then once you have escaped or you have come out of it, and later on what happens, you start to associate that feeling of getting entrapped, feeling of uh, being kidnapped. Okay, you start to associate that feeling of getting entrapped every time you will hear running water. And then this running water will induce fear in you every time you would hear running water. Okay, so that is how we form associations and that is how we develop fear. Similarly, if you have had an accident, so you would start to associate the fear, the terror you had gone through with being in the car, and later on start to develop fear of being in that car. Okay, so that is how conditioning takes place. Then other causes explanations about developing specific phobias is a behavioral evolutionary explanation. And according to this theory, we it says that some phobias, some fears, if you would observe, some fears are more common in human beings compared to other fears. Okay, and theorists or researchers argue that these fears are very species specific and it has an evolutionary factor involved in it. For example, like, see, all of us, like, in our whole life, we might have never ever come across a snake, or we might not have seen a scorpion, but still we have this fear about snakes, this phobia regarding snakes. So what these theories they call is that it's something called preparedness, because human beings are theoretically more prepared to acquire phobias, certain phobias than others, because these fears will help you to survive in an evolutionary sense. Okay, this model basically explains why some phobias, snakes, spiders, are more common than people fearing houses or tree or something like that. Okay, so researchers do not know like if these predispositions are due to evolutionary or environmental factors, but they have observed that certain phobias are more common in population compared to others. Okay, and second is what there is another type of phobia called social anxiety or social phobia. And what causes social anxiety? Cognitive theorists believe that people with this disorder hold a group of some beliefs, some assumptions they hold, and these assumptions, these rules or beliefs which they have, will work against them in social situations. For example, they hold very unrealistic high standards about themselves. Like, they believe that, they should perform in a certain way in a social situation. And they should, like, if they're having a conversation with anybody, they should contribute to that conversation, and they should be speaking something very, uh, something very important. Otherwise, and otherwise people will judge them, and they actually fear, people are having social phobia, social anxiety. They fear being judged by others. Okay, and they view themselves as unattractive, or not being good enough, and they have a very poor sense of self-esteem and self-confidence, and they believe that they are always in danger of behaving incompetently in social situations. They firmly believe that they will do something wrong, they will commit some error, they'll do some blunder, and they will be judged. They believe that inept behavior in social situations will inevitably lead to some terrible consequences, such as, like, people will laugh at them, make fun about them, talk behind their back. So they believe that they have no control over feel, and which in turn leads them to feel very anxious, and they believe that they have no control over feelings of anxiety that get triggered when they are in social situations. They don't understand that it is these thoughts, these assumptions, these rules which they have set for themselves that is triggering their anxiety. They don't, instead of that, they firmly believe that, uh, uh, you know, this anxiety, this distress which they are experiencing is because of the social situation, because they'll be judged harshly. Okay, so they'll tend to avoid as much as possible social situations. Okay, and now next, obsessive compulsive disorder. Okay, as we were talking about classification systems, previously in DSM-4 TR, obsessive compulsive disorder was placed on was actually under anxiety disorders. Okay, so now this fifth edition of Diagnostic and Statistical Manual, in this, what they have done is they have taken obsessive compulsive and related disorders and given it its own chapter. Okay, so but anxiety is, is still, see, these obsessive thoughts triggers extreme anxiety in people. Okay, so I think, so that is why this was, placed under, what you can say, uh, before the publication of DSM-5, it was considered a type of anxiety disorder because, as I was saying, these obsessions, these obsessive thoughts, or uh, continuous intrusive thoughts would create heightened level of anxiety in people. So they had placed it under anxiety disorder. But now they, a lot of research and later realized that OCD is a huge spectrum. It is a huge umbrella under which different types of disorder have a place. Okay, but your lesson is covering this disorder in this chapter, or less. Okay, I mean, this does disorder in this lesson, so we'll be talking about this. So obsessive compulsive disorder. So obsessive compulsive disorder is a condition involving repetitive, unwanted, anxiety producing thoughts. These thoughts are very intrusive in nature. Okay, what do you mean by intrusive thoughts? It's intrusive thoughts are unwanted. These thoughts, they come out of nowhere. Okay, and the person experiencing thoughts, and these thoughts are very distressing in nature. Okay, and because of these anxiety producing thoughts, the person wants some relief from these thoughts, and to get relief from these thoughts, they will perform some compulsive rituals or behaviors, which will in turn help them to get some relief or protection against this anxiety which is triggered by the thoughts. And these thoughts can be like, obsessions, or obsessive thoughts may focus on things such as fear of contamination, germs, cleanliness, a need to have certain things in certain way, very rigid, uh, a sense of, like, they have order, so certain things have to be placed in particular way, objects have to be placed in a particular way, and if those things are not placed in that particular way or manner, if things are not set according to their uh, thoughts, then they will experience heightened level of anxiety, or sometimes they'll have disturbing thoughts regarding very negative, disturbing thoughts regarding taboo topics. Okay, so obsessions are defined as unwanted and upsetting thoughts or impulses, while compulsions are defined as irrational rituals that are repeated over and over again in an effort to control or neutralize the anxiety brought on by the obsessions. So, I just mentioned, so a person would experience unwanted, intrusive thoughts, thoughts coming out of nowhere, and these thoughts could be about, like, cleanliness or germs, or these thoughts could be about uh, you know uh, a very taboo subject, could be like a sexual thought about something, some pictures, some gods, or could be like, a thought that, harming, suddenly a thought out of nowhere could come, like, uh, that, harming a very important person in their life. And these thoughts will trigger such a heightened level of anxiety in them that they would want to do something to neutralize, to stop these thoughts. They want to, to neutralize or control or stop these thoughts. And they'll come up with, in their mind, they'll come up with some certain some behaviors. For example, like, continuously feeling anxious regarding germs, or they have touched something and they find that, it could have been unclean, and their hands are not clean enough, and it will lead them to experience such a high level of anxiety. And for them, in their mind, is like, I have touched something unclean, or something is not clean enough, it is full of germs. So the solution, immediate solution, is, let me go and wash my hands. Okay, let me clean that thing. And then they'll perform that behavior. Okay, and then what will happen? The moment they'll go and perform that behavior of washing their hands or cleaning their hands or cleaning whatever surface, immediately they'll feel a relief, from anxiety. And that relief is so, addictive. This relief is, it's so good. They feel so good from getting that, after performing that behavior, that relief, that, it this that looks as if a solution to them. And then later on, whenever, as I told you, like an addiction, or OCD is almost like an addiction. A person will start, initially, with one peg of an alcohol, and and then whatever, he might feel that, he is able to get away from stress, or whatever reason he started drinking. And then later on, to get that same relief, slowly, steadily, as he's drinking, regularly, he'll have to increase that amounts of alcohol, isn't it? And one fine day, even one bottle will not be enough to give him that initial relief which he got from that one peg. So OCD is almost similar to that. So these thoughts, it they just don't go anywhere. So after getting a relief, again after some time, next day again, if he touches here and there, those thoughts will come out of nowhere. Okay, and again for him, he'll or her, this immediate solution is, he or she will go and wash hands. And then while washing hands, they'll select, they'll not, it will increase to 2 times, 3 times, 4 times, and washing in particular way, washing for so many times. So to get that relief, initial relief, they'll continue this obsessive behavior. Okay. So, the what is the diagnostic criteria for obsessive compulsive disorder? So, diagnostic criteria is presence of obsessions and or compulsions. Obsessions are recurrent anxiety-producing thoughts, impulses, or images that are intrusive, unwanted, and inappropriate to the current context. And it causes the person, the sufferer, to attempt to ignore or suppress the thought, impulses, or images, or to neutralize them with some other thought or action. Okay, for some people, if they have this thought that they'll harm somebody, or if they have a very anxiety producing thought, so what they will, it can be a mental action, or it can be a behavior also. So sometimes they will chant some numbers in their mind, recite some numbers, recite some prayer, or perform a particular action, like, putting these things from this year to that year. So they'll come up with their own magical solutions. And compulsions are ritualized behavior, for example, hand washing, or mental acts, which I just mentioned, such as counting, that the person feels driven to perform in response to an obsession, or according to rules that must be applied. These rules are in his own mind. The person will come up with his own set of rules, okay, according to rules that must be rigidly applied and are intended to magically prevent some dreaded event or situation. So, magically prevent, like, for example, a child or an adolescent or even an adult. Suddenly, he or she has a thought, their family member has gone out, and suddenly he or she has a thought, like, what if they'll be in an accident? So, that thought, just having a thought that, something happening to your important family member can produce high level of anxiety. And what happens with such persons is that, for them, like, just because now I have thought about it, so what if it will come true? Okay. So for them, they take so much of responsibility, like, that they have thought about it, so it will come true. And that creates such a high level of anxiety, then they will do something to neutralize that. So I'll just go and chant these many, prayers for these many times. I'll count numbers from here to there, or I will recite something. Okay. So that is how they feel that, if I do this thing, this act in my mind, I'll be able to neutralize this thought, and then nothing will happen to the person which I was worrying about. Okay. So at some point in the disorder, the person has recognized, they understand, they recognize, because yesterday I had mentioned neurotic and psychotic disorders. Psychotic disorders, they will not have an insight. Neurotic disorders, these people have an insight. They know that what they are doing is excessive or unreasonable, but they still cannot help it. They try to stop themselves, but it's, well, it doesn't work for them. Okay. The obsessions and compulsions cause significant distress to the person, are time consuming. So time consuming, there are impatience who will, for them, these cleaning rituals, they become so time consuming that, they have to take bath in a particular way. They have to arrange, they have to wash the buckets, the bathroom in a particular way, then take bath in a particular way, apply soap so many times in this direction, and then pour water so many times, and then getting ready, and then before getting ready, putting clothes on a particular place which is clean enough in a particular way, then getting dressed in a particular way. So these rituals, the way they will perform, will become so time consuming. They have been patients, like, if they have to go to office by 9 o'clock or 8 o'clock, they'll get up at 3 o'clock, 4 o'clock in the morning, so that they do all of this and then be ready. Okay. So they are time consuming and interfere with the person's normal routine. The obsessions or compulsions are not, again, yeah, yesterday also I've told you, you cannot diagnose a person as having OCD if that condition is better explained by any uh, physical condition, like medical condition, or if the person is taking medicine and that medication is triggering these symptoms, then you cannot call the person as having OCD, or it is induced by drug. So these obsessions or compulsions should not be due to any medical condition or medication or drug. Obsessions usually focus on a specific area, such as fear of contamination, disarray. Disarray means things are not in their proper place. Everything should be in a particular place. They get very disturbed if things are, not put in order, not in order, and everything is a mess. They cannot tolerate. Or aggressive, destructive thoughts, sexual thoughts, or socially inappropriate behavior. Obsessions may also take the form of repeated doubts. For example, like, worrying that, doubting themselves, doubting that whether they have closed. Did I lock the door? Did I lock the door? Did I switch off the stove? Did I switch off the gas stove? Did I switch off the iron? Okay. So continuously doubting themselves, and the compulsive behavior which they perform is repeated checking. They'll go back, check it, and check it, then again they'll come out, then again doubt themselves, then again go back and check. So they doubt their own senses. Okay. So repeated doubts regarding, whether they have performed a particular act, and then going and checking and rechecking. That is the compulsive behavior. So what is the etiology? Etiology means causal factors. What is the etiology of OCD? According to psychodynamic perspective, anxiety disorders develop when children come to fear their impulses and use ego defense mechanisms to lessen their anxiety. But you have to understand that in OCD, it differs from other anxiety disorders in that, see, it is responsible for your unconscious drives and your motivations, your desires. And usually these desires, as I mentioned, they are unconscious. Your impulses, your desires, okay, are usually unconscious in nature. But in OCD, this battle is not unconscious. It is played out in overt thoughts and actions. Okay, so if the impulses are either obsessive thoughts, and the defense mechanisms which are employed by the person are the counter thoughts, or the compulsive behavior are performed to neutralize or stop or control these obsessive thoughts. And according to behavioral perspective, in a fearful situation, individual happens to perform a particular act, for example, washing hands or reciting. And when the threat lifts, they associate the improvement with the random act. And after repeated association, they believe the compulsion is changing the situation. For example, like, you are in a very threatening situation, or you fear for your loved one, and then during that fear or during that threatening situation, they happen to perform a particular ritual. Okay. And then from then onwards, every time something they are fearful, they are performing that. And in their mind, they believe that because I performed this ritual, that threat went away. And then and a sort of an association forms. Okay. And they believe that because I did this, I'm able to change the situation. Okay. And they believe that because they've performed that particular act, it helps them to bring luck, it wards away any evil, etc. And this act becomes a key method to avoiding or reducing anxiety. And according to cognitive perspective, cognitive theories begin by pointing out that everyone has, that is true, all of us have a little bit of OCD. Okay, all of us have a little bit of OCD in us. Okay, and these unwanted, repetitive, intrusive thoughts are, free floating. We cannot control our thoughts, and we don't bring about our thoughts. Thoughts, they come out of nowhere, and in a day we have millions and millions of thoughts. Okay, the thoughts, they come, they go. Sometimes thoughts are very good, very bad, philosophical, funny, idiotic. I mean, we can roam all over the world by sitting at one place. Okay, so everyone has repetitive, unwanted, intrusive thoughts. All of us have it. But people with OCD, they blame themselves for normal, although repetitive and intrusive thoughts, and expect that terrible things will happen as a result. They believe that just because I have had this thought means something will happen to my family, something will happen to that loved one. They hold themselves responsible for that thought or something bad happening to them. And to avoid such negative consequences, because now I've thought of it, now this bad thing will happen to them. Okay. And they feel they are responsible, they have they feel that they, that power over something happening to the loved one. And now to avoid something bad happening to them, they will attempt to neutralize their thoughts with actions or any other thoughts, like, something they will perform, some ritual they will set for themselves. Okay. And that they believe will help to neutralize those thoughts. And these neutralizing thoughts or actions will include, they'll seek reassurance, going and talking to somebody, and, like, nothing will happen to them. Now they are going this. So they will get some sort of a reassurance from other people. No, 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 they've just gone here, and then they'll come back and this, or thinking good thoughts, opposite thoughts, or washing, depending upon what type of intrusive thoughts. If they have thoughts regarding contamination or germs, they'll indulge in repetitive washing. If they have doubts regarding whether they have switched off the stove, or locked the door, or switched off the iron, they'll go and repetitively check. So you might ask, if everyone has intrusive thoughts, then why only some people develop OCD? Because people with OCD tend to be more depressed than others. They have exceptionally high standards of conduct and morality. Okay, they don't give themselves a break. They don't understand that we are human beings, and it's okay. Sometimes we have some bad thoughts, sometimes we have shameful thoughts also, sometimes we have weird thoughts also, and it's okay. But they have like very high standards of morality and conduct, and then, like, it disturbs them very much if something negative, they think about something negative, and they believe thoughts are equal to actions and are capable of bringing harm. So there is, just because I thought of it, then I'll go and do it. They don't understand there is difference between thinking and going and performing that action. Okay. And they believe that they can and should have perfect control over their thoughts and behaviors, and that is something nobody can do it. Nobody has control over thoughts. Okay. And if some method previously, some years back, we had a technique called thought stopping, and that technique doesn't really work. And nobody can stop. If somebody promises to teach you thought, they'll help you to stop your thoughts, they are lying, because nobody can stop thoughts. If I ask you not to think about an elephant, can you?
Oh, ma'am.
Huh?
No.
No,
No.
ma'am.
Thoughts is getting
If I
going.
ask you not to think about an elephant, can you do that?
The first you
We
start
can.
to think about the elephant itself.
Yes. So the more you will try not to think about elephant, you'll think about elephant. And second thing which you are doing is, or you'll say, don't think about elephant, don't think about. So what are you doing? You're practicing at it also. So when you're practicing, means practice makes perfect. So you will think more about that elephant. So thought stopping technique doesn't work. Okay. And you cannot control your thoughts. You cannot, stop your thoughts. Okay. So, and people with OCD, they believe that they have perfect control over their thoughts and behaviors, and that is where things go drastically wrong. Okay. And what is the biological perspective? How does biological model explain OCD? And two recent research has provided more direct evidence into biological cause. They found that a neurotransmitter called serotonin, it has been found that abnormal activity in serotonin is been linked with OCD. Okay, and evidence that they have shown evidence that serotonin-based antidepressants reduce, and that is why the medicines which are the treatment which is given, medication treatment, is targeted towards correcting this imbalance. So they have evidence has shown that serotonin-based antidepressants, those medicines, if they are given, they reduce OCD symptoms. Okay. So recent studies have also shown that there are other neurotransmitters which also play a significant role, an important role in triggering OCD. But serotonin has been found to be majorly having an effect, abnormal activity of serotonin. And regarding brain structure, they have found that abnormal OCD is linked to orbitofrontal cortex and caudate nuclei. So this orbitofrontal cortex and caudate nuclei, they are composed of brain circuits. Okay. And what do brain circuits do? Brain circuits convert sensory information into thoughts and actions. Whatever information we get through our senses, we have five senses. So those sensory information is converted into thoughts and actions from these two structures of the brain, orbitocortical functus and caudate nuclei. Okay. So either these, they have found that either this area is maybe too active, and because of which, in people who are having OCD, and because of which, which leads to troublesome thoughts and actions in people who have OCD. Okay. So now coming to the last, again, this disorder, and post-traumatic stress disorder, uh, in DSM-4 TR, it used to be a part of anxiety disorders. But now what they have done is, like OCD, they have removed this and placed it into its own category. Okay. So, but then it is being covered in this lesson, so I'm going to talk about it. So, the category which they have placed under is trauma and stressor related disorder. Okay. So, what is post-traumatic stress disorder? The main criteria here is uh, person has been exposed to some sort of trauma, and after being exposed to that trauma, the person is you know what is trauma? Trauma is an overwhelming, emotionally overwhelming experience in which there is a possibility of death or injury to yourself, the person, or their loved ones. Okay, so you might have been a very serious accident, uh, experienced a very serious natural calamity, dangerous situation. Okay, so a traumatic event, uh, very very dangerous situations such as a person who have been raped or been involved in a very situation, serious situation where there was a possibility that they might die or somebody very close to them. And I'll explain these two things: acute stress disorder. So what have they under uh, post traumatic stress disorder? They have not explained. I don't think they have explained this into your lesson. But in DSM-4 it is split into two. So after experiencing trauma, okay, obviously, if you have been through a trauma, you will experience lot of anxiety. Okay, you will experience significant amount of anxiety after going through that trauma. Okay, so if these symptoms they occur within 1 month of that traumatic experience, then we call that as acute stress disorder. And if these symptoms they occur,
Pardon, ma'am.
pardon,
Can you please repeat that? PTSD and acute. You
that's
were
what
just
I'm
telling.
saying. That's what I'm saying. After experiencing trauma, it's very natural to experience anxiety symptoms such as difficulty in sleeping, feeling nervous, worry, panic, fear, all those anxiety symptoms a person will experience. Okay, sometimes they'll have flashbacks related to that trauma, memories, hypervigilance, startle response, hypervigilance, like they'll be continuously alert. Startle response would be like even if there is a sound also, they will just startle. Okay, simple small sound can also startle them. So after experiencing a trauma, the person will experience anxiety symptoms, post-traumatic anxiety symptoms. If those anxiety symptoms are within 1 month, then we give a diagnosis of acute stress disorder. And if the symptoms go beyond 1 month, go for more than 1 month, then it becomes post-traumatic stress disorder. Clear? It's the duration.
Okay. Okay, ma'am.
Okay. So, following a traumatic experience, some people experience the symptoms. I'll be describing in the next slide. Whole list of symptoms I'll list out fastly. And in so if these symptoms last more than 2 days but less than a month, then we will call it as a person as experiencing acute stress disorder. If symptoms continue for more than 1 month, or basically begin more than a month after the trauma, okay, so for at least 1 month nothing is happening and suddenly after a month the person is experiencing these symptoms, then we call it as post-traumatic stress disorder. Okay, so according to DSM-4 it post-traumatic stress disorder, there are three types of post-traumatic stress disorder: acute, chronic, and delayed onset. In acute type of post-traumatic stress disorder, here when symptoms last for less than 3 months, then we call it as acute post-traumatic stress disorder. And if the symptoms last for more than 3 months, then we call it as chronic PTSD. And delayed onset would be when at least 6 months have passed after a traumatic event, and then the symptoms get triggered after 6 months, then we call it as post-traumatic stress disorder with delayed onset. Okay, so the likelihood of developing a stress disorder following a traumatic experience is increased by length and intensity of the exposure to danger. So how much and how severe the exposure you had with the traumatic incident, and for how long you were exposed to that traumatic incident. So, for example, war situations. Okay. So, how severe and how long you were exposed to a traumatic situation or a danger can increase the likelihood that you will have PTSD, or whether the person already had some pre-existing emotional problems, or there is a history of prior traumas in his or her life. And also it could be triggered by guilt over surviving the trauma. That is, he or she survived and the loved one did not survive. And also by lack of social support. There is nobody around the person to really help and provide that support. Okay, all these factors will contribute to development of PTSD. Okay, so what is the diagnostic criteria? The person experiencing a traumatic event, person experiencing traumatic, these are the criteria. The first, foremost, and the most important criteria is you cannot call a person as having PTSD if he or she has not been exposed to a traumatic event. Okay, and even involving the possibility of death or serious injury, and the person's response involves intense fear, helplessness, or horror. Traumatic event is persistently re-experienced in one or more of the following ways. And how that event is re-experienced, that is recurrent, intrusive, distressing memories of the event, recurrent, distressing dreams about the event, acting or feeling as if the event is occurring, flashbacks, that is what we call as intense psychological distress when exposed to internal, external cues that symbolize or resemble an aspect of the event. Cues could be, smell, for example. Have you ever experienced suddenly if there is a smell and immediately a memory gets triggered, you associate a particular memory with particular smells, yes or no?
Yes, ma'am.
Yeah. So if particular smell can trigger them, okay, if that smell is associated with that event, or it could be a sound, okay, and that could also trigger them. And physiological reactivity is followed, that is heart pounding, sweating when exposed to these cues. Person avoids reminders of the trauma and experiences a numbing of general responsiveness. Okay, they will try to avoid thoughts, feelings, or conversations. They will not want to talk about about the trauma, any conversations associated with the trauma. Efforts to avoid activities, places, or people that arouse recollections of the trauma. Inability to recall important aspects, so they will try to suppress the memory of the trauma. Marked diminished interest or participation in activities, everyday activities, feeling detached or estranged from others. Restricted range of affect. Affect means emotions. So they will feel, lack of feelings, lack of certain feelings, dulled emotions. Person experiences persistent symptoms of increased arousal as indicated by at least two of the following. He or she should experience at least two of the following of the list: difficulty in falling or staying asleep, irritability or outburst of anger, difficulty concentrating, vigilance. I told you, isn't it? Always they will be in a state of alert. Okay. Continuously hypervigilance is continuously vigilant. They will be exaggerated startle response. Small sound can also make them startle. Disturbance causes significant distress or impairment in normal function. Okay. So uh, we have talked about, brief summary is what, generalized anxiety disorder involves chronic pervasive nervousness. It is free floating anxiety. Worry is the main core factor in generalized anxiety. Panic disorder involves episodes of acute terror known as panic attacks, which need to worry about experiencing future panic attacks. Phobias are persistent and unreasonable fears of particular objects or situations. Obsessive compulsive disorder involves anxiety producing unwanted thoughts or impulses, that is, obsessions, and uncontrollable rituals meant to decrease anxiety, what we call as compulsions. Post traumatic stress disorder and acute stress disorder involve a variety of anxiety symptoms that occur in the wake of a traumatic experience. And what is the treatment for anxiety disorders? There are two types of treatment. One is psychotherapy, and the second is medication. Okay, so psychotherapy would be the best type of treatment, or the most effective form of psychotherapy is cognitive behavior therapy. Okay, so cognitive behavior therapy has been found to be
Sorry.
very effective with, yes,
What is that first method, ma'am? Psychotherapy, the best method?
under psychotherapy, The most effective form of psychotherapy is for anxiety disorder is cognitive behavior therapy.
Okay.
So, two types of therapies, two types of treatment basically, medicines and psychotherapy. Okay, psychotherapy is will help people to learn how to manage their emotions, emotional, cognitive, and behavioral aspects of anxiety. And the most effective form of psychotherapy for anxiety disorder is cognitive behavior therapy. Clear on this? See, clear on
Yes,
this or
ma'am.
not? What
Yes,
do we
ma'am.
do? I mean, psychologists, we do psychotherapy, isn't it? And we have different types of therapies, different forms of psychotherapies. Okay, uh, from those, cognitive behavior therapy has been found to be most effective. And this approach, cognitive behavior therapy, focuses on helping people identify the automatic negative thoughts and cognitive distortions that contribute to feelings of anxiety. Okay, so and techniques under cognitive behavior therapy is exposure therapy. Okay, it is a technique or a type of cognitive behavior therapy that is very helpful for some types of anxiety. Okay, here people are gradually exposed to the things that they fear, often while so just suddenly we will not expose them to whatever they fear. First, we will teach them relaxation techniques so that they are able to help calm their body's stress response, because I told you anxiety comes with physical symptoms, isn't it? So they have you teach them relaxation techniques. We have different types of relaxation techniques, and you teach them relaxation, and then once they learn those relaxation techniques, then slowly gradually we expose them to the things that they fear. Okay, so and this exposure is systematic in nature. Again, suddenly they fear a spider, I will not place spider on their hand. So first, I will make a hierarchy. First is like, maybe think about a spider, then looking at a picture of a spider, then maybe, a plastic spider. So they can just touch a plastic spider, then spider in a glass box, then later on, maybe going near the spider. Understood? So, systematic exposure to anxiety provoking situations or thoughts, learning to substitute positive. So, what do we do under cognitive behavior therapies? Exposure therapy, that is systematic exposure, then helping them to substitute, because they have these automatic negative thoughts, isn't it? Helping to learn to substitute positive behaviors and thoughts for negative ones. We teach them new coping skills such as relaxation exercise, breathing techniques, etc. Okay. And what is the medical treatment? A drug treatment or medical treatment, whatever you want to call. These medicines are given to reduce the symptoms of anxiety by influencing brain chemistry, that is targeting neurotransmitters. So antidepressants, such as Tropinol, Paxil, these are some of the treatments, and benzodiazepines are given to people having obsessive compulsive disorder. Other type of treatments are, helping, teaching them managing stress through a healthy lifestyle, such as, resting, sleeping. Having a sleeping is very critical for mental health. Exercise, nutrition, social support. And if they are in a habit of taking excessive alcohol and drugs, see, people have misconception that alcohol reduces stress, but actually it is other way around. Too much of alcohol triggers excessive anxiety. Okay, so moderating their alcohol or drug intake. Okay, so this is what, with this we finish your anxiety disorders. I thought I will finish off maybe personality also, but anyways, okay. So we will start with personality. We have maybe 15 or 10 minutes. I'm thinking of requesting this BROU people to not cut off immediately at 9 o'clock, and then maybe, not cut me off at 9 o'clock, and maybe give me half an hour more for at least 2 or 3 classes, not every day, so that I can finish it off. Let's see. Are you all agree? I mean, fine with that?
Yeah, ma'am.
Yeah, ma'am.
Yeah. Yes,
Because,
ma'am.
automatically they cut me off at 9 o'clock, and then I'm thinking whether they will.
We request, ma'am.
Yeah, I'm thinking I'll request because I'll have to tell, like, I have to tell them, like, it's nothing to do with the payment or a fees. It's to do with, like, I have to finish your lessons and
Or maybe one or two extra classes in the month of June, ma'am, when we have only one paper in those 12 days.
Yes. It's also useful.
whatever, but at least one or two classes I need. Okay, I mean, because
That's better, ma'am, because the
because
only
talking
one
about
class we are left
disorders,
out with.
psychological disorders, this is a huge area, and I cannot just rush. Let's see. Okay, so now let's start with we have 10 minutes, almost 10 minutes. We'll start with a personality disorder. Okay,
Okay, ma'am.
so yeah. Mm, I'll start with screen share. Okay, can you see this? Can you see this?
Yeah, ma'am.
Okay, so
Yes.
personality disorders. Now, personality disorders, let's start with, basically having an overview. What exactly is our personality disorders? Okay. So, persons having or individuals having personality disorders, they will face chronic interpersonal difficulties. Okay. So, in a way, you can even call them as interpersonal disorders. Persons having personality disorders, they'll have difficulty in interpersonal or social situations, even close relationships also, family members, love, they'll experience difficulties in those situations also, in those relationships. Okay. And people with personality disorders have problems with their sense of self or identity. Okay. And they'll show maladaptive traits that are enduring. So compared to psychotic or neurotic or other disorders, there is no complete cure for personality disorders. Okay. Personality it starts right from your childhood. Okay. It's like, foundation of your whole when the personality is, it's very integral to a person. Okay. So these traits, well, the maladaptive traits, are enduring, inflexible, and pervasive across a broad range of personal and social situations. And people with, so the prognosis, the outcome is, we are not, there is no medicine for personality disorder. Okay. And maybe some symptoms, if they experience some symptoms because of the personality disorders, the medicines will be given to take care of those symptoms, but there is no cure for personality disorder. Yes, but lot of rather than medicine, psychotherapy has been found to be to some extent effective. So till the person is coming for psychotherapy, you can still make that person be on track. Okay. So but it is a very chronic uh, type of a no? Personality is very pervasive and enduring in nature. So onset can be traced back at, to adolescence or early childhood. So you can see even in childhood, during adolescence or early childhood, those typical maladaptive traits in a person, like, you can see, like, those personality, those forming, like, you can see that something is wrong, something, the way they behave, the way they think, their thoughts, thinking, emotions. Okay, that can be seen traced right from early childhood. And personality disorders are egocentric rather than ego dystonic. What do I mean? What do I mean when I say, what is this term egocentric and ego dystonic? Ego dystonic means, see, your symptoms, your behavior is creating distress in you, and you're not happy with that behavior. Okay, so people with OCD, with anxiety disorders, okay, they are not happy. They want some help. Okay. They are not comfortable with their behavior, their emotions, their thoughts. So that is ego dystonic. It is not in line with their ego. Okay. It they are very uncomfortable because of ego syntonic means they are fine, they're okay. You know, it's they, the person feels that this his behavior is completely fine, completely normal. It is other people who are uh, in the wrong. Okay. So ego dystonic means their behaviors, values, and feelings are uh, not in harmony or acceptable to the goals or needs of the ego. Okay, it's not consistent with their self-image. And egocentric means they're happy, whatever they're feeling, their values, their behaviors, completely acceptable to them. So people with personality disorders are egocentric. They find that their behaviors, it's not them who are wrong, it's other people who are in the wrong. Clear on this? So when a person starts to think that the problem is not in me, I am completely fine. It is the others who have to change. It's there. The problem is theirs. Then you cannot really help people with personality with disorders, isn't? So what is the general diagnostic criteria for personality disorders? Uh, Enduring pattern of inner experience or behavior that deviates from expectations of culture. It is not in line with the culture the person belongs to. It deviates from the cultural norms. Okay. And this deviation is manifested in two or more of the following: cognition, that is how the person sees himself and others; affectivity, the way the person experiences emotions; intensity, the range of emotions expressed by the person; interpersonal functioning, not getting facing extreme difficulties, not getting along with family members, with not having enough many friends, even while in job also, not able to stick to a particular job. Impulse, and the people will also have problem with impulse control. And these pattern this enduring pattern is inflexible, pervasive in many situations. Enduring pattern leads to distress, impairment in important areas of function. That is, they'll not be able to function socially or occupationally or academically. Okay, pattern is stable and of long duration, can be traced back to childhood. Pattern not better. Again, this should not be explained by any other disorder. Should not be because of substance abuse or alcohol abuse or medical condition. Okay, so now according to DSM-4, DSM-5 also, ICD, what ICD has done is, in ICD-10 we used to have all these disorders. Okay, not DSM has clustered these disorders under cluster A, B, and C. ICD did not have any clusters, but ICD had all the disorders which are shown in the slide right now. But now currently what ICD has done is, in ICD-11, what they have done is they have removed these names of all the disorders, and they have just given a general description which I just mentioned of personality disorder, and they have uh, given specified or as mild, moderate, or severe personality disorders. Okay, so mild personality disorder, severe personality disorder, moderate personality disorder. And additionally, they have given some 5 personality traits such as negative affectivity, detachment, dissociation, disinhibition, and ankastia as personality trait associated with that mild personality disorder with detachment, moderate personality disorder with disinhibition, like that. So what they have done is they have removed all the names which I am showing in the slide in DSM in ICD-11, and just put mild, moderate, and severe personality disorder with these traits. And whichever traits applies to that personality disorder, they will add to the diagnosis. Okay, but in DSM, they have retained, DSM-5 has retained these clusters. Okay, so we are going to go according to DSM-5. Clear on this?
Yeah, ma'am.
Yeah. So according to DSM-5, uh, we have like 10 personality disorders split into 3 clusters: cluster A, B, and C. Okay, so why they have made clusters is that there is a core feature to every cluster. Okay, cluster A personality disorder includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorders. And this cluster is marked by odd behavior, eccentricity, but they are not psychotic in nature. Because you might be, the words paranoid, schizoid, schizotypal. So they are not having any psychosis. Okay, uh, but they show marked eccentric behavior, very odd behavior, and superficially they share a similarity with schizophrenia. You can even say a milder version of schizophrenia. Actually, the way they have made lessons, they should have actually gone after uh, anxiety disorders. They should have gone with either mood disorders or schizophrenia. But anyways, so that is why the disorders uh, showing eccentric, odd behavior, superficially almost like schizophrenia, they have clustered that under cluster A. Okay, paranoid, schizoid, schizotypal, and disorders. And cluster B personality disorder contains antisocial, borderline, histrionic, and narcissistic personality disorder. And what is the core feature of this cluster is people belonging, the conditions, the type of personalities coming under this cluster, they are marked by they are very self-absorbed. They are prone to exaggerate importance of events, importance of themselves. Okay, heightened level of self-importance is seen in these personality disorders. And these personalities, people with these personality disorders, they have very, they exhibit difficulty in maintaining close relationships. And cluster C personality disorder is marked by, people are often anxious, fearful, and depressed. And the disorders coming under this cluster C uh, are avoidant, obsessive compulsive, and dependent disorders. And the core features in these disorders are, anxiety, fearfulness, and depression. So now we will, maybe tomorrow, we will start cluster A, and that is cover each and every disorder under every cluster. Okay.
Okay,
Because
ma'am.
even if I start now also, it doesn't make any sense.
Yes. In 1 minute, we're going to disconnect.
Within a 1 minute only, they will shut it down. So maybe what we can do is, if they don't allow it, so maybe by ourselves, maybe we can set up a time, and we can decide on a time, and then I'll request them. Let's see what they say about it.
Actually, the fourth class we have not yet started, ma'am. So before that, after completion of these classes, however, we are left out with the topics. Those topics we can ask them, and based on not only two, if it is possible by 3 or 4 classes, we can ask them. And we, it's
The only thing is, like, my problem is I am going out of station.